Ladies and gentlemen, good afternoon. It's my pleasure as President of the International Society of Gynecological Endocrinology to invite you to participate to that webinar that we organized with the support of Milan, that I warmly thanks very much for their unrestricted grant and their support in this occasion. As you know, in few days, at the beginning of December, we will have our ISG Congress starting from Florence. It will be the first time with a full online event. But today we have another full online experience, is that fantastic webinar on one of the major topics that we are facing in this year, is the menopause symptom management, facing needs and fears. This is something we have touched the clinical activity of all of us, which was in the newspaper and journal since 20, 30 years, and still we have a huge debate. And you will hear this afternoon from the presentation of our invited guest, how to face the menopause symptoms management and how to face the needs and the fears. Today, the speakers are Professor Petra Stute from the University Clinic of Bern and Professor Nick Panay from the Imperial College of London. All of you know already them, but just few words about them. Professor Petra Stute, she is certified in OBGYN in 2005, and in 2008 she had the subspecialization of gynecological endocrinology. She's member and board member and treasurer of German Menopause Society, and she has deputy director of the section of gynecological endocrinology and reproductive medicine since 2009. She is the head of gynecological endocrinology, actually, at the Women's Hospital University of the Clinic in Bern. She's president of the Swiss Menopause Society since 2017 and board member of the European Menopause and Andropause Society. Nick Panay, who knows? Nick Panay from the Imperial College of London. She's specialist in gynecological endocrinology at Queen's Charlotte and Chelsea and Westminster Hospital and honorary senior lecturer at the Imperial College. He is the past chairman of the British Menopause Society and is the general secretary of the International Menopause Society. He is in the board of Climacteric, the journal of the International Menopause Society, and also in the board of GREM, the new open access journal of the International Society of Gynecological Endocrinology. Then, thanks to all of you, enjoy that fantastic webinar, and I leave now to Professor Nick Panay, the chairmanship of this session. Have a good time, enjoy the life, stay safe, and we will win the COVID and all. But also we have to take care and win our menopausal patients. See you soon.
Andrea, thank you for that rousing introduction. It's a great honor to be with you all today with my wonderful colleagues. And I hope that we will share some really interesting information over the next hour or so. What I would like to do is start with some introductory slides. I will then introduce Professor Petra Stute's presentation. I will then give a presentation myself, and then we will end up with some questions and answers, which hopefully will answer the burning questions that you have about menopause, hormone therapy, and the practical management of your patients. So, first of all, I would like to share the following information with you. These are my disclaimers. As a result of the EMA Pharmacovigilance Risk Assessment Committee recommendations in May 2020, where they emphasize the risks of breast cancer with HRT, and the data came largely from the Lancet paper, the collaborative Oxford group, published towards the end of last year. The key societies, or some key societies globally, such as the British Menopause Society, IMS, EMAS, RCOG, and AMS, published a consensus view that the meta-analysis from Oxford did provide some important additional information on the risk of breast cancer with MHT. However, the group felt strongly that this should not be interpreted in isolation and needs to be considered in the context of the overall benefits and risks associated with MHT to help women make an informed choice, and that no arbitrary limits should be placed on the dose or duration of MHT. The decision should be made on an individualized basis and should be considered in the context of the overall benefits obtained from using MHT, including symptom management, improved quality of life, and cardiovascular and bone protective effects associated with MHT. And finally, that discussions on the risks of breast cancer with MHT should also include the findings from the WHI placebo-controlled randomized trials and the large E3N observational studies, which reported on the risk of breast cancer in users of micronized progesterone and digesterone compared with other progestogens. Now, neither of the two studies were included in that meta-analysis. And I think in a symposium where we're talking about menopause symptom management, facing fears and needs, it's really important to fully understand why there are fears out there, but to put those fears into perspective with the overall data that we have. And I hope over the next hour, we will be able to put these data into context and help you in the practical management of your patients. So with that, I'm going to stop sharing my screen and I'm going to invite Professor Stute to give her presentation on menopause symptom management in daily practice. So, Professor Stute.
Yes, thank you very much for the introduction. And I'm happy to talk about finding the right treatment approach in daily clinical practice. So my goal is to be really practical, and I would like to share with you how I am dealing with menopausal women on a daily practice. So this is my official closure, and this is my private disclosure or conflict, because my goal is that I can offer an all-round carefree package to the menopausal women who are coming for consultation for me. So that's the challenge. So let's imagine we have a 54-year-old woman presenting with menopause 2.5 years ago. She has hot flushes and insomnia since 3 years, and she really feels worn out, always being tired, and she forgets everything. She has mood swings, and apart from that, she has a severe vaginal atrophy, so she's not in the mood for sex anymore. And she has put on body weight, and her body weight has increased by 8 kilos, and she's very unhappy about this. So, and in her personal history, she has had a venous thromboembolism twice, and she doesn't really know if she has been tested for thrombophilia. She also has had a breast biopsy, which was okay. However, her aunt had been diagnosed with breast cancer, so she's very concerned about this issue. So when we are sitting in front of such a woman, we might think at the beginning, okay, I'm a gynecologist, so I can deal menopausal issues. But then we might think, well, am I also a neurologist or a psychologist or a sex therapist? Or am I also a nutritionist, an internal medicine specialist, and a breast expert? So most likely we are going to answer this question, most likely I'm not a hybrid of all these medical disciplines. However, that's exactly what women want. So specifically, they want us to listen to them and to take them seriously. And they want clear and evidence-based information on menopause and treatment options. And that's probably the biggest challenge. They want counseling on topics beyond conventional gynecology, such as weight management, sleep disturbances, fatigue, and sexual function. And of course, all women are different. So we have to deal with their individual and cultural attitudes at the same time. And that's why a couple of years ago, in EMERS, we thought about a model of care for healthy menopause and aging. And this is the result. That's a position statement. And the keywords are healthy, menopause, and aging. So what are the goals of the model of care for healthy menopause? First of all, we wanted to provide a health care and health promotion for midlife women, and we also want to empower them to make positive choices for their well-being and post-reproductive health. And of course, also on the individual level, we have certain goals. So we want to set up a personalized care plan, which should comprise short, mid, and long-term goals. And of course, not only in the context of physical symptoms, but also in the context of psychological and social functioning. And of course, we have to take the women's perception into this goal plan. So this seems to be very difficult. So the question that arises is, how can we put this model of care into practice? And the good news is we are not alone. So first of all, it's necessary to have some kind of structure. Structure, this means an interdisciplinary healthcare network. So most likely the menopausal woman will first consult her GP or her general gynecologist. And in most cases, most symptoms are quite well resolved with the help of the GP or the general gynecologist. However, if there are multiple issues, like in our case, then it's sometimes necessary to go a step further and to consult a specialist center. And in this specialist center, ideally there is a lead clinician and a specialist nurse. And this lead clinician has a lot of friends in his clinic to whom he or she can talk to. Because in this age, women more or less will be confronted with some kinds of non-communicable diseases, such as coronary heart disease, back pain, musculoskeletal diseases, depression, diabetes, and so on. And it's always good to have some friends of other medical disciplines that we can ask, because it's not necessary that we know everything, and it's also not realistic to know everything. So it's good to have a cardiologist, a neurologist, a rheumatologist, a psychologist, and so on, that we can easily ask for backup medical expertise. Secondly, it's good to have a structured process. This means it's good to have a standardized assessment of women's needs, diagnostics, and a treatment algorithm. And I will shortly show how I am doing this in my daily practice. And of course, it would be great to have an ICF-based assessment, and I will also show to you what I mean by that. If you have not heard the term ICF before, this is something the WHO introduced a couple of years ago, and they want us to also look at functioning. Usually we also only look at the diseases, so at the ICD classification, but they also want us to look at the functioning of a woman and to also classify it accordingly in a standardized manner. So that's the pathway the patients in our clinic have to go through. So if a woman comes for the first time, usually she will be addressed first by a nurse, and the nurse will take her blood pressure, heart rate, body height, body weight, and BMI, waist circumference, and then also will do some urine and blood tests later. Then the woman fills in a so-called modified menopause rating scale, which I will introduce to you in just a few seconds. And after that, she comes to me. And I will take her personal and family history. I will do a gynecological and breast examination. And then we create together something I call wish list. And that's really my favorite thing. And it's always more or less funny to have a look at what the wish list looks like in different patients. And after that, we are defining the rules of the game. or in a more professional way to say this, we are doing something called shared decision making. So that's the menopause rating scale. That's the conventional one you most likely know. So here we have like 11 menopausal symptoms, and the woman can rate the severity of the symptoms from none to extremely severe. And a couple of years ago, we added 2 columns. So there's one column saying I need immediate treatment, and there's a second column saying treatment maybe later. So if I see the symptoms and the severity of the symptoms, and if I also see immediately if the woman needs urgently treatment or maybe treatment later, this already helps me to guide the discussion. And in a study, we linked the menopause rating scale. So here you can see all the conventional symptoms that are presented in the menopause rating scale. So we linked them to the ICF. But more important for us now is that, again, like in the conventional MRS, menopause rating scale, the woman can write down how severe her symptoms are in the different categories. And what I think is quite important is also to assess how the degree of relief should be, because we always think that a woman wants to have a 0 after our treatment, but that's not always true. So a lot of women say, well, you know, now I'm on a degree of 3, I'm very happy if it's a 1 afterwards. So that's good to know what how severe the symptoms are and what kind of relief she's expecting from us. And also it's good to know in a time frame what her short-term goal is, what her midterm goal is, and what her global goal is, because this also gives us a feeling how urgently the treatment should be successful. But now I also told you about my wish list, and this is how this wish list looks like. So usually I ask the woman, so what's your number 1 priority, which should really be better as soon as possible? And let's say that's one of the most frequently given answers. She doesn't want to have any hot flushes anymore. And she wants to improve her mood. She wants to sleep better. She wants to lose weight. She wants to look younger, and so on and so on. And that is actually our to-do list. So her wish list is our to-do list, or my to-do list. And then I address all the single symptoms, and we are trying to find a treatment or a possible treatment combination that treats as many symptoms as possible. So for example, our woman tells us she wants to reduce her hot flashes. So I will tell her that we have some alternative treatment options like phytoestrogens, herbal products, acupuncture. We also have non-hormonal pharmacotherapy like antidepressants. And of course, we have the menopausal hormone therapy. Then I take a look at her second symptom, depressive mood. Again, we have some non-pharmacological treatment options like psychotherapy. We have alternative treatments like herbs. We also have non-hormonal pharmacotherapy like antidepressants. And again, we have menopausal hormone therapy. And finally, to improve her sleep, again, we have some non-pharmacological treatment options like psychotherapy. Again, we have alternative treatment options like herbs. We have some non-hormonal pharmacotherapy like antidepressants or non-benzos. And again, we have the menopausal hormone therapy. And then we can discuss with the woman what treatment combination would be best for her to start with. This can be either a herbal product or a combination of different herbal products. This can be a menopausal hormone therapy. And of course, this can also be an antidepressant. So, and I think it's good for the woman to see that, first of all, different treatment strategies can address her symptoms. And it's also good to see that there are that a change of treatment options or combinations is always possible. And now let's have a closer look at menopausal hormone therapy counseling. And that's a very easy slide and very easy to understand for most women. So I'm always talking about the pros of MHT. I'm talking about the cons of MHT. And this is more or less the list I showed to women that are healthy and below age 60. And then we see that the list of pros is quite long. So most importantly, her menopausal symptoms are quite likely to be reduced. Then there's a positive impact on her bone health, heart health, brain health, and her body weight will also stabilize. And she will have a preventive effect for type 2 diabetes. And her skin and her hair will also be happy. On the cons list, first of all, we have the increased risk of venous thromboembolism and stroke. This is also dependent on comorbidities and of course of the age of the woman. And most importantly, this risk specifically applies to oral estrogens. So that's easy to change to a transdermal product. Then the only thing which is actually staying on the cons list is the breast cancer risk. But again, here it's important to remind the patient or to discuss with the patient that breast cancer risk is not increasing from today until tomorrow, but that it's a question of time. So usually breast cancer risk has been shown to be increased after more than 5 years of combined therapy with estrogens and progestogens. However, it's important to keep in mind that the official indication for menopausal hormone therapy is the climacteric syndrome and osteoporosis prevention. Okay, so now let's say our patient is willing to try a hormone therapy. Then the next question will be how to decide which MHT we should choose. So the first question will be, does our patient have an intact uterus or not? So if she still has a uterus, and this also includes a woman who had an endometrial resection. So in this situation, we always should combine an estrogen with a progestogen. As estrogens, we have estradiol, and in some countries, we also have conjugated equine estrogens. And we have different kind of progestogens that we can choose from. And of course, as you will see later, we have various dosages. We can offer transdermal or oral preparations, and we can use the estrogens and the progestogens in a sequentially combined or continuously combined combination. And in some countries, it's also the combination of a levonorgestrel intrauterine device combined with estrogens is also approved for hormone replacement therapy. And of course, we can offer tibolone to the woman. If she does not have a uterus anymore, then the first choice would be any estrogen or tibolone again. So let's have a closer look at the estrogens. So that's a list of various estrogens that are available in our countries. And most importantly, we first have to have a look at what kind of oral estrogens are available. And as I've already said, we have a lot of products containing estradiol, and we still have, at least in some countries, products containing conjugated equine estrogens. So that these are oral preparations. And then we have some transdermal preparations, and they come as patch, as gel, or as spray. And then the dosage can vary. So we can have a high dose hormone replacement therapy. We can have a standard dose, low dose, or ultra low dose. And let's have a closer look at the standard dose, because here you can see then how the equivalent dosages are. So for example, 2 milligrams of oral estradiol corresponds to a 50 microgram patch And that corresponds again to 2 pushes of the estrogel gel. And then if you divide the dosage by 2, you will have the corresponding low dose estrogen therapy. And if you divide it again by 2, you are on the ultra low dose dosage. For the progestogens, we have more than just 2 types of hormones available or types available. So we have nortestosterone derivatives, we have progesterone or 17-alpha hydroxyprogesterone derivatives, and most of them are also known from hormonal contraception. We have 2 exclusions. So the dydrogesterone and the micronized progesterone, they do not play a role in hormonal contraception as they are not inhibiting ovulation, but they play a huge role in hormone replacement therapy. So micronized progesterone is what we call a bioidentical hormone. It has a central nervous effect, meaning it's decreasing fear, and it is sleep inducing. So that's an effect a lot of women are happy to have. Also, there are women who do not want to have a CNS effect. And for those women, it's great to have another progestogen, and that's dydrogesterone. And that's a retroprogesterone of progesterone. And this doesn't have a central nervous effect. So as I already said, it's not inhibiting ovulation, and it's not having any kind of possibly negative impact on the brain. And for both of them, we can say that there's no negative impact on metabolism, coagulation, and the cardiovascular system. So having said all of this, the women and I are going to the start. So we will choose one of those buttons here, and then after about 2 to 3 weeks, we will have a telephone call. And at this telephone call, I will get a first idea how the woman likes or does not like the treatment we chose together. Then after 3 months, she comes back to the clinic, and we will have a closer look at her wish list again. And maybe we will discover that we already reached all her goals. So that would be the best scenario. Then we just continue with the treatment we started with. However, it's also possible that we need some kind of fine-tuning of the current treatment. And sometimes it's also necessary to completely change the treatment, or to ask some other friends of us or other medical experts to help us. So now I come to the conclusion. So the challenge is that midlife women want us to deal with all kinds of menopausal, but not always only menopausal symptoms, but also a lot of worries and health issues. So what is the solution? The solution is to have a structure, which means a network of colleagues from other medical disciplines that can help us. And we need standardized processes so that we are able to easily and quickly assess the woman's needs, perform our diagnostics, and that we have a treatment algorithm, including counseling on hormone replacement therapy. And then we have our toolkit. So we have a lot of treatment options that help us to treat the woman according to her needs. We have tons of variants, various estrogens, applications, dosages, and so on. We have different kind of progestogen types, dosages, and application forms, which all together will help us to face this challenge. Thank you very much.
Petra, thank you very much for that very practical and comprehensive overview of menopause management. I think that will have helped a lot of people in understanding how they should be approaching their patients. So I would now like to go on to my presentation, which will involve evaluation of new global data in order to improve women's experience in menopause. Because surveys have consistently demonstrated that women experience menopause transition symptoms that have substantial negative influence on their quality of life, And this is compounded by perceived lack of support from family, friends, healthcare providers, and employers in fully understanding the impact of menopause on their lives. So as well as these socio-cultural perspectives, the studies also suggest that there is lack of knowledge, lack of understanding, and lack of appreciation of menopause management options amongst women, partners, employers, and their healthcare providers. And it's very worrying that help is only sought by many women when their symptoms become moderate to severe. And in my view, and I'm sure Petra as well, prevention is better than cure. So if you have somebody whose symptoms are getting progressively worse, they need to seek help sooner rather than later. I'm delighted that we have some new data for you from 2 large observational surveys performed in women 45 to 55. These were 20-minute online surveys with a number of questions, and the questions were posed to European women in 6 countries, and also there was an Australian arm to the survey. And the aim was to understand pre- and menopausal women's knowledge, expectations, and perceptions about menopause and management options. So these are the results. There were over 7,000 women surveyed, over 6,000 across 6 European countries, as you can see there, and over 1,000 in Australia. The majority of women were peri or postmenopausal, but did include a significant proportion of premenopausal women. The majority were in a relationship and mostly working, and most of the classes, I would say, were surveyed by this study. The average age of menopause hormone therapy users was 51. That's no great surprise. That's the average age of the menopause. Those with menopause symptoms had on average 5.5 menopause symptoms when they were using MHT versus 4.6 on average in non-users of MHT. And European women using MHT were more symptomatic than non-users. Again, no great surprise. About 70%, so the majority were helped by MHT. 22% said that all symptoms improved, including vasomotor symptoms and also mood changes. And there were significant quality of life improvements on MHT in terms of feeling good about themselves, good health, and also in terms of satisfying sex life. There was some difference in terms of sex life between Europe and Australia. It may be that the indication for hormone therapy is different between Europe and Australia in that context. The main results really on MHT and the main views on MHT was that 90% of the population were aware of MHT, but only 13% in Europe were actually using it and 10% in Australia. Poland had the highest rate of use at 23%. Premenopausally, 29% believe they could use MHT. So perhaps it's a little bit surprising that by the time they get to the menopause, there is a drop off in the percentage that do actually use it. And 16% were actively against MHT for various reasons. And in Germany, that went up to 1/3 of women that were surveyed were actively against using hormone therapy. In the Australian survey, about 1 in 5 Australian women were against MHT for various reasons. Around 50% did not like the idea of taking hormones, or they had a fear of cancer risk, or in 45% they believed MHT is not natural. In 29%, they said that they had seen negative effects of MHT in others, so it's important that we minimize risks and side effects when we're prescribing. And some of them had fears perhaps that weren't fully supported by the data from modern hormone therapy prescribing, in that 27% had a fear for stroke and 26% had a fear for heart attack. So the key points for discussion are that there are persisting fears and misperceptions regarding the safety of MHT. Despite the benefits, only a small proportion of women are using MHT currently. Women using MHT are more symptomatic, but not substantially so. And therefore, that indicates that there are other factors which influence the decision to use MHT. And despite the many society recommendations, IMS, BMS, EMAS, ISGE, women and healthcare providers, I believe, still lack accurate evidence-based information. For instance, their concerns about heart attack, even though MHT, when commenced in the window of opportunity, can be cardioprotective. So I think it behoves us to convey and to work towards the way of mitigating the fears in order that we can address the unmet needs, because menopause symptoms are not going away. And what we need to do is optimize menopause hormone therapy. Now, if we have a look at the IMS recommendations from 2016, they say that the increased risk of breast cancer is primarily associated with the addition of a progestogen to estrogen therapy and related to duration of use. And of course, breast cancer is one of the greatest fears that women have about using MHT. 3 studies suggest that micronized progesterone or digogesterone could be associated with a lower risk than synthetic progestogen. And a large European observational study, the E3N cohort, suggests that micronized progesterone or digogesterone, when used with estrogen, may be associated with a better risk profile for breast cancer than synthetic progestogens. And a registry study from Finland reported no increased risk with digogesterone after at least 5 years of use compared to synthetic progestogens, which were associated with a small increased risk. So now what we have to do is look at the differences between the different types of MHT as far as breast cancer risk and progestogen and progesterone content, because it's not a class effect. What we can see here in breast cancer cell lines in vitro is that there is a greater proliferative effect of progestogens such as NPA and NETA, norethistron acetate, when used with estradiol, but when dydrogesterone or progesterone is used with estradiol, there is either a pro-apoptotic effect or a balance between apoptosis and proliferation. So that would suggest that these types of progestogens and progesterone are safer to use. So let's have a look at the E3N data and the Finnish data in a little more detail. This is the baseline risk without MHT. This is with estrogen and micronized progesterone, and this is with estrogen and digogesterone. And likewise here in the Finnish cohort, we can see the data in women using estradiol and digogesterone compared to the baseline risk without MHT. And as you can see there, there is no significant difference statistically between the risks with estradiol and progesterone and digogesterone compared to the women without MHT. But there is an increased risk in women using other types of progestogens there, as you can see here with NPA, norethistron, and other progestogens in general. So breast cancer risk in this study, certainly up to 5 years, was lower with natural progesterone and digogesterone. These are data from the UK GP research database, looking at estradiol and digogesterone here in orange compared to other MHT in gray and no MHT in green. And again, you can see with estradiol and digogesterone, there is a trend to a lower risk of breast cancer within this GP research database population. And we also saw similar findings to this study from today's publication in the BMJ on a case control nested study, which showed that the risk with digogesterone for breast cancer were the lowest. And even in the collaborative group on hormonal factors in breast cancer, which one might say might represent the highest risk in terms of the studies looking at breast cancer, what we can see is that the risk with digogesterone does appear to be lower than the HRT preparations, the MHT preparations containing other progestogens. But I think we need to think further than just about breast cancer, because there are other potential benefits to manipulating the dosage and regimen of hormone therapy. So lowering the dose of MHT, for instance, appears to have a dose response effect on stroke risk. These are the data from the Nurses' Health Study, and we can see that the relative risk for conjugated equine estrogens, 0.3 milligrams, is below unity, whereas the risks are increased if higher doses of conjugated equine estrogens are used. What about VTE and estrogen dose? Again, we can see a dose response effect with lower doses of conjugated equine estrogens here, having a lower relative risk with oral types of estrogen. What we're doing at the moment at Imperial College London, with, in collaboration with John Stevenson, is that we're trying to see if we lower the dose of estradiol with digesterone sufficiently, can we achieve neutral effects on VTE risk when compared with transdermal estradiol and norethisterone. That study is ongoing, and we hope to bring you the data within the next year. But reducing the dose of estrogen also has the benefit of reducing the incidence of spotting and breakthrough bleeding, which is very important if we're going to encourage compliance and continuation of therapy with hormones, with hormone therapy. So we can see here in this study, comparing 0.5 milligrams of estradiol with 2.5 milligrams of digesterone in pink, to 1 milligram of estradiol with 5 milligrams of digesterone in gray. There was a placebo arm for 3 cycles as well, and then these women went on to use the 0.5 milligram dose. We can see that the incidence of breakthrough bleeding is lower to begin with, which encourages continuation of therapy. But then as we get closer towards the end of the study, the curves meet, which indicates that the risk of breakthrough bleeding becomes very similar. But the start, I think, is very important. So if you have symptoms that are not particularly severe, then you could start with the lowest dose of hormone therapy and increase the dose if required. So talking further about VTE risk, we know that progestogens may modulate the increased risk conferred by oral estrogen. Perhaps that's through venous dilation and pooling. And we see no increased risk or reduced risk of VTE in progesterone and digesterone users, even with oral estradiol administration. And this was seen in the E3N study and also in the ESTER study, which I'm going to refer to now. So this is the ESTER case control study, 271 consecutive VTE cases versus 610 controls using various types of hormone therapy. And we can see here that women using micronized progesterone or pregnane-derived progestogens with their MHT, such as digesterone, had no excess risk of VTE, unlike those using oral estrogen or norpregnane-derived progestogens with estrogen. And we have here data from 2 nested case control studies from the UK GP research databases. Over 80,000 women matched by age to 391,000 female controls. And what we can see here is the women using conjugated estrogens with MPA had the highest risk, and those using estradiol with digesterone had the lowest risk of VTE, and the transdermal preparations were not associated with a risk of VTE. And finally, just to refer to side effects, because ultimately, as well as risks, we need to minimize side effects if we're going to encourage women to use hormone therapy. And we know that MHT with more androgenic progestogens can lead to skin problems such as acne, greasiness of the skin, excess hair growth. There can be fluid retention due to mineralocorticoid effects, and these effects are mitigated through the use of less androgenic progestogens, and also PMS type side effects seem to be less with the less androgenic progestogens. So side effects such as low mood, anxiety, and irritability. So again, we need to be selective in the types of hormone therapy we're using. So in conclusion, only a small proportion of women were using MHT in Australia and Europe, according to our survey, and 1/3 did not feel adequately informed regarding menopause. And this is, I think, due to over-reliance on often unvalidated internet sites, lack of healthcare provider support, and also due to fears and misperceptions regarding MHT safety, which I've mentioned. So what are the next steps? I think we need better education for women, employers, co-workers and friends. We need more resources and educational opportunities for healthcare providers. And this will facilitate engagement with women more effectively regarding their menopause and the choices they have to make for the next half of their lives. And this will enable us to truly individualize menopause therapies to optimally address needs and minimize fears. I have a case study here, just very briefly. Gloria, 50, presents with an erratic cycle, vasomotor symptoms, mood swings, and brain fog. BMI, a little bit elevated, 29, but she's a non-smoker, no history of VTE. Lifestyle measures, including diet and exercise, have already been tried. And she wants something that works quickly and prefers an oral preparation. She was started in primary care on oral sequential estradiol with norethistran, 1 milligram of estradiol, 14 days of 1 milligram niter. And when she returned to our menopause clinic, she reported a 50% improvement in vasomotor symptoms, but no improvement in mood or anxiety. And she was complaining of bloating, headaches, and acne in the last 2 weeks of the packet with the different colored pills. So the problems in this case were inadequate symptom control. She needed a higher dose of estrogen, progestogenic side effects. So we changed the progestogen, and we did actually switch her to the Femoston 210 range, 2 milligrams of estradiol with 10 milligrams of digesterone in combination. And we have advised the review in 3 months. She returned at 3 months and reported a complete improvement in her vasomotor symptoms, but also on the higher dose of estrogen, her mood, anxiety, and joint pains felt better. And she was not experiencing the bloating or headaches in the second half of the cycle. She had good cycle control and was happy to continue on the treatment. So I think what this case demonstrates is that as long as the body mass index is below 30 and the individual can have oral hormone therapy, there is no need to consider transdermal preparations. The starting dose of estrogen was inadequate to control VMS, mood, and cognitive problems, and that's where she benefited from a higher dose of estrogen. And the type of progestogen very much matters. She had less adverse effects with digesterone containing MHT. And of course, you've seen from the data that from the slides that I've presented, that it is safer if oral MHT is used with digesterone or micronized progesterone rather than with more androgenic progestogens. So with that, I would like to thank all of you for listening to my presentation. And I would like to go on to the question and answer section of our webinar. And if I may take Chairman's prerogative to ask the first question for Petra, which is the majority of women do not feel prepared for menopause and do not use MHT or do not take MHT into consideration. How do you advise this patient, and which MHT do you recommend in your practice?
It depends a little bit in which reproductive stage the woman is. So if she's in the early menopausal transition and if she only has minor menopausal symptoms and more or less a regular cycle, then we probably discuss herbal preparations to start with. However, if she has symptoms or if she is already in the late menopausal transition or in the postmenopause, then usually I suggest a combined therapy. And depending on the severity of the hot flushes, I use a low dose or a standard dose estrogen. And if she's still in the menopausal transition, I choose a sequentially combined hormone therapy. And if she's postmenopausal, I choose a continuously combined MHT.
Thank you very much. Another question which has been asked by a number of the delegates, and I'm happy for you to answer first, and then I will contribute as well, is your approach to reduce libido, and also whether you consider the use of androgens.
Yes, so I discuss with the patients that of course loss of libido can have multiple reasons, and that changing of the hormones can be one of the reasons. Then I'm checking the hormones to see if there's anything I can improve, also the thyroid, for example. And then we discuss conventional hormone replacement therapy. and also using some androgens. And also, yeah, so that's the answer, both of it.
Yeah, and the problem is, of course, Petra, that there is a very limited range of options that we can use for androgens in women. In some countries, they use DHEA. In the UK, we use lower doses of the male gels, usually 1/10 of the dose of Testigel or Testim gel. There is a cream called Androfem cream, which can be accessed privately from Western Australia. And I think the important thing to emphasize is that as long as we deliver the right dosage for women, the female physiological dosage, the risk of androgenic side effects is extremely low, isn't it?
Yeah.
And as far as we can tell, although the data from a randomized perspective are not very, very long, no increased risk of cardiovascular disease or breast cancer, but we do need longer term data. And I'd just like to guide people to the International Menopause Society website, where Professor Susan Davis has, in collaboration with other societies, has produced an excellent consensus statement on testosterone.
So I always stick to this global consensus, and I'm always happy we once had the Intrinsa patch so that we know that the 300 microgram per day were okay of testosterone.
Somebody's asked about Tibolone. Do you use that in your practice?
Also, yes.
Yeah. The problem with Tibolone, I find, is that it's not very estrogenic. So if you have somebody with quite severe menopause symptoms, sometimes it's not enough to fully address those.
That's why I always have my wish list, you know, then I know where the focus of the woman lies on, and then I can decide which product to choose first.
And if you have a woman that comes in to see you that has fears specifically about breast cancer, how do you try to reassure her on this? Again, we had more data today from observational and case control data as opposed to randomized trial data suggesting that the risks may be higher, but you and I suspect that these are trawling perhaps old data sets where women were using more androgenic types of progestogen. We've now moved on, we're using biosimilar, bioidentical type hormones. How do you reassure women in your practice?
So I usually use absolute numbers. So I'm telling her that if we imagine we have 1,000 women at the age of 50 right now in this room, and all the 1,000 women will meet again in 5 years, and none of them will have taken any hormones. And we ask the 1,000 women how many of those will have been diagnosed with breast cancer in this time, then 14 women will say me. And then if we now imagine 1,000 women, same age group, around 50, they all go home with a combined hormone replacement therapy. And again, we meet in 5 years and we ask the group, who of you has been diagnosed with breast cancer in the meantime? Then around 18 will say yes. So the difference are 4 cases within 5 years.
So it's about talking in terms of absolute numbers rather than relative risks, which sound much more alarming. That's excellent. There have been a couple of questions on herbal remedies as well. I don't know if you want to address those. I can say a few words.
Of course. So as we all know, there are a lot of different herbal products available. Not all of them are approved as drugs by the official authorities. And but for example, if the woman is in her early menopausal transition and the hot flushes are not severe, then a lot of women are happy to start with herbal products like black cohosh, for example.
Yes, I agree. And I think one of the important messages is that it is a quality product that's chosen, because there have been 1 or 2 cases of liver toxicity with black cohosh. And I think that's where there was perhaps some contamination with blue cohosh, which can be liver toxic. But also red clover can be of benefit, fermented soy. And there's also a new one, which is a pollen extract now, which can be used. So I think it's about tailor making, again, your recommendation, to that individual woman's requirements and what she feels comfortable with. There was a question about migraine, managing, particularly with aura. Do you still prescribe in women with migraine with aura?
Yes, but only transdermal estrogens and only with a neutral progestogen, so either progesterone or dydrogesterone.
Yes, I agree with you. Transdermal, start relatively low and then increase the dose carefully if required. There's a very interesting question here. Well, you may not. How do you define menopause?
Okay, well, that's not, you're right, you're not so easy. So it's a question of menstruation. So officially, as we all know, if there's no spontaneous menstruation anymore for no other reason, then we know that this last menstruation was menopause. But obviously that's not always so easy because women are taking all kinds of hormones and then you do not really know when menopause actually happened. So I think for the practical reason, it's more important if a woman still has her menstrual cycle to distinguish between the early and the late menopausal transition, because if you know where she actually is from her bleeding profile, it's easier to define the dosage of estrogen she probably needs.
Then there is a question on buying over the internet, such as progesterone cream or gel.
No good idea.
I think we have not a good idea.
No.
And I particularly worry about the women that use the progesterone bought through the internet together with estrogen,
Absolutely.
which may be insufficient to give them adequate endometrial protection. But I don't know, sometimes it's as if they feel they're getting something different. How do you advise them about these situations?
Well, I tell them that if they use progesterone transdermally and estrogens at the same time, that their risk for endometrial hyperplasia and possibly endometrial cancer is increased, and that the progesterone is not going sufficiently through the skin. And then of course I change their regimen. But I agree, it takes a lot of time and discussion because a lot of women do not understand why it's possible to get something via the internet or via pharmacies if it's not good or safe from the medical point of view. But I changed their regimen.
I think that's very sensible, and that's what we do as well. So I'm going to finish with two questions, both of which are dear to my heart. Perhaps I will ask you to address the first one and I will address the second. Managing severe vulvovaginal atrophy, GSM symptoms, how do you approach that issue?
Okay, let's say I'm sure it's really a question only of estrogen decline, because first of all, I have to be sure that it's nothing else which is causing the symptoms. So let's say I'm sure it's a menopause related change. Then most of women that come to my office already have tried several non-hormonal products. So I'm not starting the 10th non-hormonal product. So most of the time we start with vaginal estrogens. And then I just ask them, do you like an applicator or do you not like an applicator? Do you like more a creamy thing or do you hate creamy and sticky things? And that's how I find out what kind of vaginal estrogen we can start with. And just like since like 2 months, we also have vaginal DHEA on the market. So that's going to be another option for us here in Switzerland and in Europe.
Thank you very much. And the final question is about premature ovarian insufficiency or early menopause. This is an area which I believe has not received sufficient care and attention from the medical authorities in terms of research. But one thing is very clear, that these young women need to have an early diagnosis in order to avoid suffering, in order to prevent the long-term sequelae of premature ovarian insufficiency, such as increased risk of osteoporosis, cardiovascular disease, and cognitive problems. And these women should be on hormone therapy at least until the average age of menopause, 51, because this is physiological replacement of hormones which would have naturally been there. And this was actually the subject of the International Menopause Society for the World Menopause Day on the 18th of October. And there is a white paper that we produced that's available free to download from the IMS website. Well, our time is drawing very near, so I'd like to say a big thank you to Petra for her excellent presentation and for fielding my questions. I'd like to thank all of you, the delegates, for listening and for your very interesting and important questions. I'd also like to say a big thank you to Professor Andrea Genazzani for introducing us, for ISGE, in combination with Mylan for hosting this meeting. And yeah, we look forward hopefully to seeing everyone, if not physically, then virtually, for the ISGE conference later this year. So thank you very much once again. Goodbye.
Thank you too. Bye-bye from Switzerland.
And bye-bye from London. Stay safe.
You too. Thanks.